Good morning, good afternoon, or good evening, everyone. Welcome to our new PREZODE webinar. The science talks and lectures we are hosting today propose a different format than the webinar roundtable sessions we have organized before. It will allow us to focus on precise analysis and case studies and share advanced scientific, technical, or methodological knowledge, research results on a specific topic. Today, I am pleased to welcome Dr. Marisa Peyre, who will moderate the session. Marisa is co-founder of the PREZODE initiative, and she's deputy head of ASTRE unit in CIRAD. She's an epidemiologist specializing in the evaluation of surveillance and control programs for animal, zoonotic, and emerging disease. She's also an expert of today's topic. Marisa, the floor is yours.
Thank you very much, Elsa. Thank you very much, everyone. Good morning, good afternoon, good evening to all of you. It's nice to see such a great participation. We are exactly 100 right now. So thank you for joining. This very important topic today, which is gender perspective in zoonosis prevention. And as you know, like various factors such as gender, age group, cultural background, and social conditions have a significant influence on exposure to disease risks. And following the webinar that was dedicated to the equity issues in zoonosis prevention and hosted by PREZODE on January 23rd, this session will deepen the focus on how gender issues are addressed in different contexts. Gender is recognized as a key determinant of inequalities in living conditions, access to healthcare services, and consequently, health protection. So the following presentation, which will provide answer to several questions, including what are the challenges, health risks, and socioeconomic consequences of gender gaps in prevention? Why is a gender perspective necessary to better understand challenges in prevention, health exposure, and care, and how we can tackle them? And also, how does integrating gender issues positively impact population health, as well as social aspects? And we can cover many more other questions during the follow-up discussion. So to explore the subjects, I am very pleased to welcome three women and scientists of exception, Dr. Magda Robalo, Dr. Natalia Cediel Becerra, and Dr. Brigitte Bagnol. So before I give the floor to our speakers, I would like to invite you, our audience, to send your question through the Q&A box that you can find on the three little dots of the Zoom menu. And those questions can be answered after the three presentations. So Magda, I will start with you. So Dr. Magda Robalo, you are president and co-founder of the Institute for Global Health and Development, and you are a former Minister of Health, High Commissioner for the COVID-19 response in Guinea-Bissau. You are also a member of the PREZODE Steering Committee, and you will give us today a global overview of the topic of the day, which is the gender perspective in zoonosis prevention. Welcome, Magda, and the floor is yours.
Thank you. Thank you very much, Marise. It's a great pleasure to be here today, joining the science talks and lectures. As you said, I will give a global perspective on why gender perspectives in zoonosis prevention are important, starting by indicating that we often refer to gender and sex as generic and synonymous, but they are not. Gender and sex are different, even though they are interweaved concepts. Sex is how we are born, male or female, and gender is how society and norms condition our behavior and make us feel male or female. Social roles and behaviors at the human, animal, and environmental interface have an influence on exposure and risk of infection and the course and severity of infectious diseases, including zoonotic diseases. This is not just for zoonotic diseases, but bacterial infections, non-communicable diseases are impacted by social roles and behaviors that people have. But specifically here, we are looking into zoonotic diseases and the interface between women, animal, and environmental context. The potential exposure to pathogens and transmission patterns of infectious diseases may be gender specific, and there are, even though very scanty, but there are some studies that have been published which demonstrate gender specific related exposure to pathogens and transmission patterns. We should talk about this. We are talking about this today, and increasingly we need to be looking into this because there is not only growing awareness of the importance of sex and gender in medicine and research, but also because we acknowledge that gender differences in health-seeking behavior, in quality of healthcare, and adherence to treatment recommendations are different from men and women, depending on the gender influence they have had in their lives. Both genetic as well as hormonal, immunological, and anatomical factors interact to influence sex-based differences in pathophysiology, epidemiology, how diseases present clinically, the severity of diseases, and prognosis. Social norms can influence, and they do influence, risk factors and exposure to infection. They determine health-seeking behaviors and impact on therapeutic decisions. The gender roles not only affect individuals, their profession, what they do, where they live, and how they do what they do, but also affect the behavior of providers in the healthcare system. So it's not only the clients of healthcare system, the patients, but healthcare system itself has an impact on the risk to exposure, the evolution of disease, because people who work in our healthcare systems also are influenced by their respective gender roles. Unfortunately, gender analysis have not been systematically integrated into research practices or resulted in changes to guidelines and prescription patterns, or even the way we look at and diagnose diseases. And in general, these guidelines, the policies that are adopted are mostly not sex specific, and they don't take into account gender analysis. However, the dimensions and the impact of sex and gender in populations affected by zoonotic diseases have been insufficiently explored. And I want to insist on this because the recommendations that I will make and that should come out of this conversation today are geared towards increasing and improving the way we research and understand dimensions and impact of sex and gender in populations affected by zoonotic diseases. The impact on demand, access, and utilization of health services and prevention and control measures still very poorly understood, and we need to make sure we increase our research on these issues to have a better understanding of how gender roles affect people health seeking behaviors and the behavior that condition the risk of acquiring infections and being diagnosed or prevent the risk of infection. In the next slide, I will briefly touch on the feminization of the Ebola outbreak in West Africa a few years ago, which was probably the turning point where people became more acutely aware of the importance of researching and taking into account the different roles, men and women, and the gender behaviors that condition how they react to participate in and address specific outbreaks or diseases that are increasingly occurring in our societies. It was noticed that the caregivers, which more often were women at home and female health workers, were at higher risk due to direct contact with infected individuals. The traditional burial rituals washing and preparing bodies increase the exposure, particularly women, because very often, specifically in Africa and many other geographies, they are in charge of these rituals. There was also an increased risk in healthcare and domestic settings, and generally women being more likely to interact in public spaces had also an increased exposure to the virus. So I'm speaking here about the gender gap, not in terms of salary pay or economic disadvantage, but just highlighting some of the few elements that we know are the difference between men and women when it comes to the gender roles they play in society. It's widely understood and known that inequality between men and women is a characteristic of our societies, more acutely felt in low and middle incomes, but still inequality between men and women are influenced by the gender roles, social norms, and behaviors that for centuries have been inserted through education in our societies. The share of women is undervalued, underpaid. Women have less access to health, education, and finance services because of the gender and social norms we are talking about. And these gender and social norms exacerbate toxic masculinity and social control over women. I will briefly talk about the context we are living in, which makes it even more important for us to pay attention to issues related to sex disaggregated data, gender roles, and behaviors. To mention but a few, the rapid spread of zoonotic infectious diseases due to spillover of new pathogens from animals to humans, which has become a global threat. There is an exponential growth of human populations and encroachment of the environment on the environment and wildlife habitats. The interface women-animal environment is quite complex, and the interactions between these three elements has been increasingly disrupted over the past decades, particularly because of increased livestock farming, land use and agriculture, increasing trade of exotic animals, international travel networks, migration, urbanization, and of course, climate change. On this pictured figure here from Cataldo et al., you can see an attempt to picture the interaction between environment, animal and humans, and you see here a village in Africa and how women in general take care of livestock, mainly poultry, and do domestic work that increase their exposure to infection. This is again another way of picturing the same concepts where professional contacts with farming animals, water or soil, or even recreational activities, sports, etc., could be factors for increasing the risk exposure of men and women in society. Very briefly described in 2021, a study in the Democratic Republic of Congo showed that men appear to be most often affected due to the higher risk of exposure to animals associated with the occupational practices they engage in, hunting, skinning, and trading, while women are mainly exposed due to domestic duties, such as contact with contaminated meat or MPXV infected family members. This is just to illustrate the difference that can influence how women and men are infected or exposed to infection to zoonotic diseases during their day-to-day activities. One major challenge, there are many others, but one major challenge I want to highlight here is the shortage of evidence-based data to enable us to further explore exposure pathways. Next slide, please. lack of data to understand risk behavior, but also to inform, next slide, to inform a gender and sex transformative approach to prevention and control, but also gender risk mitigation measures and exposure prevention strategies. Next slide. Just in a way of concluding my remarks here, I wanted to bring in the connection between the Sustainable Development Goals, One Health, and the conversation we are having here around gender roles and the influence of gender in prevention of zoonotic diseases. Gender equality is critical for us to achieving all the 17 SDGs, and empowering women and girls positively impact health, nutrition, agriculture, and climate action. I should not leave the impression that for particular zoonotic diseases, depending on the gender role they play, depending on their profession, their activities, their risk behaviors, men could be more at risk than women. But in this presentation, I did highlight the conditions and the situations that put women more at risk of infection and exposure to disease. But there are particular diseases that we would see that men are more at risk. But we need to build the body of knowledge in order to, and have sex disaggregated data in order to better understand how these factors influence the risk of exposure of men and women. So working on gender equality will be critical for us to improve also our understanding of how zoonotic diseases impact the economy, impact the health outcomes of people, and how can we influence those elements. As a way of conclusion, I have a couple of recommendations which look into how we could integrate gender into One Health approaches. Community engagement with the gender lens is important. Healthcare workers need to have access in order to improve their understanding of how all this affects men and women differently, and alert their knowledge and understanding of approaching men and women differently. We need to have better understanding of the socioeconomic impact of exposure to zoonotic disease infection on women, but also, of course, on men. And of course, not forgetting that global collaboration is required. This is, again, some more specific recommendations on gender sensitive data collection and analysis that we need to do, and beyond health, because we are talking about the context and the interaction between animal, environment, and women. We also need to look into not just health, but the elements around agriculture, which are some of the activities, farming, etc., that women engage in, not forgetting that education and empowerment of women are particularly important. Thank you so much. I hope I have not exceeded the time allocated for me to talk about this issue. Thank you so much, Marisa.
Thank you so much, Magda. No, the time needed to be taken. That was a very enlightening presentation. I mean, you have highlighted the links between gender and zoonotic risk and disease, potential exposure pathogen that may be gender specific, and you have shown the need to consider gender inequality far in health beyond the issue of salary and undermined role, which is also a big issue, as you've said. And you've said we should talk more about it, especially today more than ever, and we are doing it. So this is great. A few words on what you say as well. I mean, you've really highlighted the need to consider social and cultural practices which are highly gendered and create increasing health issue in women, as demonstrated by your case studies. And last but not least, I mean, you have made a very clear call on research to focus more on and integrate more the issue of gender and health and the impact, to measure the impact of this issue that has been insufficiently explored, and you have given us recommendation on how to do so. So thank you very much. This is very great, and we can all use this to move on to do better research. Now, to complete the to carry on, I am now pleased to welcome Dr. Natalia Cediel Becerra, which is an associate professor and researcher at Universidad de La Salle in Colombia, and a member of the One Health high-level expert panel. And Natalia will bring a more in-country perspective, showing case study in the rural context of Colombia, and the Amazon region. Natalia, the floor is yours. Thank you very much.
Thank you very much, Marisa. Can you hear me? Is good?
Yes,
Okay.
very well.
You can see the presentation?
Yes, as well, very well. Thank you.
Thank you. Thank you very much to the PREZODE team for the invitation and the opportunity to present and to share the experience that we have done in Colombia, especially in the Universidad de La Salle, regarding the generation of evidence and the importance of bringing this academy and policy interface and how we can achieve a better, more sustainable and more equitable world. So I would like also to start acknowledging that Latin America is the most unequal region of the world. We have, for many decades, have this place, this shameful place, and I would like also to pointing out that in the creation of the One Health definition by the WOLEP in 3 years ago, we really acknowledge the importance of equity, inclusion, and access, because we couldn't start talking about One Health without acknowledging the difference, the regional difference, not only in the world, but within the countries. And actually, I want to mention that the Joint Plan of Action is based on the principle of equity, parity, and transdisciplinarity. And that's why it's part of also our responsibility as researchers to understand the importance of including women empowerment and adopt the gender perspective in what we do. So that's one of the the context of this presentation. Also, I would like to mention that with my research group, we have trying to generate evidence, because in my region in Latin America, we are lacking a lot of data regarding the equity and regarding the importance of including social groups as part of the not only understanding the problem, but also understanding how we can solve the roots of this situation. So 2022, with a colleague and some students from veterinary medicine, we made a scoping review, a systematic review, trying to understand the prevention of exposure to zoonosis in rural Latin America, because it's in rural parts of the region that we have the main gender gaps and social gaps. And we found in this review that one of the socioecological factors was inequality. Actually, we point out that how low education level belonging to a minority of neglected community and the lack of deficient public services are truly barriers to the prevention of zoonotic diseases. You can then to have access to this presentation, and you can explore more the other aspects of what is blocking Latin America to really have zoonotic disease prevention. But focusing on Colombia, I want to point out that Colombia has been the second most unequal country of my region, and now is the first place is Brazil, but before pandemics, COVID-19 pandemics used to be Honduras, but Colombia has been the second place. Why we have this inequality in our country? Because we had a civil war, 62 years of civil war, and that creates a lot of the roots of the civil war actually was the ownership, the land ownership and control and access, because we have land concentration on very few hands. So that creates a whole situation, negative situation regarding the poverty. As you can see in this graphic, the rural poverty is 3 times higher than urban poverty in my country. And you can see situations like, for example, the National Observatory of Health did a study on the relationship between social class and health determinants, social determinants of health. And they found that rural informal workers and peasants were the population at with higher proportion of the population with lack of access to clean water, with houses with earthen floors, and with lack of waste management and excreta collection in my country. They have other health indicators, like, for example, the indigenous communities and Afro-descendant communities, where the population with highest rates of maternal mortality and infant mortality. So that's absolutely unfair. And that's why we are connecting now how, for example, this situation can be tackled, the sustainable development goals, and how actually this context can be a vicious circle among poverty, inequality, and better and more diseases, no, in this population. And diseases that are related to the human, animal, and environmental interface. In Colombia, we have what is called the feminization of poverty in rural Colombia. We have, as Dr. Magda shared previously, we have no data that can be found on rural women living conditions. We have a care economy where these women have higher unpaid work due to these gender roles that are cultural based. No, this is part of the what has been done for many years and is continue doing. And we have limited access to clean water, healthcare access, and sanitation services, lower opportunities for education that creates that these women can only be employed in the informal labor market. This is this vicious circle that I was mentioned. And the disproportionate limited access to land, credits, and technical assistance with a strong influence of patriarchal and traditional social norms. So all these situations can limit the autonomy for women in making decisions about how to invest in health promotion or leadership roles in prevention activities. So as Universidad La Salle is very aware of the social situation in the rural Colombia, we are bringing alliances, and also we are promoting research that is part of the solution. No, we have done a lot providing evidence, but we want also to be part of the solution and to create possibilities and opportunities for change. So I want to present the Gender Transformative Capacity Building Project that we have. Is an ongoing project right now with families in the milk cheese value chain in Caquetá. Caquetá is part of the Amazon region of the country, and it has gender gaps that you can see. 94% of women perform unpaid work. There's a highest rates of domestic and sexual violence, and there is a highest teenager pregnancy proportion in the country. He has the first place on that. So with Diana Sanchez, the PhD student working in this project, we have we have done the last 2 years a process of gender action learning system, which is GALS, which has been used for Oxfam and many other international agencies. We have using WELI, which means the Women Empowerment in Livestock Index. And we have also included the research on milk safety test. For anyone who is interested in understanding these methodologies, we are really happy to share all the research that we have done about methodologies. And we are inspired by our colleagues in Africa that they have developed a lot of resources, and we are learning from them. And so what we have found, first, she's Diana, and Diana, I hope she's here. I think she's here listening this. I'm very grateful that she allowed me to present, and that we are learning together about how to bring this gender transformative capacity building, because what we feel is that we can be gender blind, not acknowledging these gender gaps, but we cannot do it anymore. We have the evidence that we need to do something, but we are not only recognizing that these gender gaps exist. We want to go one step forward, that is changing and transforming these gender norms, because they are man-made. They are not natural, and they can be transformed. So how can we do this? With a lot of participatory methodologies, qualitative methodologies, in-depth interviews. We have done workshops and trying to understand what limits the participation of women in those workshops and in those capacity building courses. So one of the key findings that we have found is when we apply the WELI index, we found that 65% of women are support staff. So they don't really do milking activities all the time or have leadership roles. They are really only occasional activities and like secondary activities in the value change, in the chain value, sorry. And 85% of women delegate the big decisions to husbands, and not only at work, but also at house level, at the household level. And we have also found that almost 80% of women have limited access to resources like training, technology, and financing, obviously because of the saturation of the household care workload. So what we have done through this methodology is changing the pattern and trying to building with them and constructing and building the solutions with them. How for example, the training can be improved. So they have proposed, and their families has accepted, to include their husband and their children in the activities of the livestock and the household care work, which is sharing the burden of the work. And also we have identified that including a whole family lunch workshops is not something to separate the women from her family, but we are integrating the whole family approach in this capacity building. So we found that from 10 to 4 p.m. It's better to do this training because they are more focused on that, and they have the family in that workshop. So we are bringing families in the picture. From the milk safety key findings, we found very interesting results. We have our intervention is the capacity building, trainings and courses on food safety and women empowerment and all these aspects. But we did a measure previously, the intervention, and we found that the average of somatic cell count in milk was 6. Let me focus on that. 635,000 cells, and in the isolation of bacteria, we found that Enterococcus spp and Staphylococcus aureus, and there were no practices for preventive measures to understand if we have preclinical mastitis, like California mastitis test or other tests that we can do. There were non-existing practice on that. After the training, we found that the count of the average somatic cells was reduced. The isolation was only Staphylococcus aureus, so the enterococcus, the environmental contamination of milk can be reduced. And also they have implemented the Californian mastitis test more routinely, no, with a more frequent aspects. And one of the most, and just closing my intervention, one of the most interesting findings was the relationship with the One Health interface, or the human health, human, animal, and environmental health. Because in these workshops, we understood that women identified the water protection and the tree conservation as the most important for livestock sustainable practices. They changed their mind in how they were focusing only the cow, but they understand that the relationship from that cow in a whole environment, especially with the bodies of water like rivers and all the water conservation, was really important. Also, the animal welfare, it was a highlight that they had as the axis of the safe dairy production. And that's why they start thinking, and they create actually an agroecological tourism strategy to not only to improve women leadership in this value chain, because they can earn some money in this tourism strategy, but also because this strategy can help to reduce or to mitigate the climate change that is part of this context. So this strategy has a conservation and protection of its resources and ecosystems, and also they commit with a zero deforestation agreement in the Caquetá cheese value chain. So for me, this is one of the better examples that how integrating gender in zoonotic preventions can have better outcomes, because as we know, deforestation is one of the main drivers of disease emergence for example, in Amazon. And as we know also, one of the recommendations of the OLEP to reduce the spillover is to address these anthropogenic drivers of disease emergence. So we have seen in this example, and that's why we wanted to share it today. We haven't finished the thesis. We are in the process of collecting the results, but we wanted to give this good news and to show also the good news that as part of the key findings of this research, Diana is also the first woman president of the regional table of Caquetá Livestock Producers Committee. So that means that through this process, we have understood that we as women and researchers, we have also an important role on taking our power positions and political participation. We cannot expect that things change if we don't use those spaces to decision make. And also, we have to understand that this changing of mindset is very slow, but that we need to keep working on that, no? Like in different creating dialogue circles between women and including men in the solutions, no? And also, pues this is an ongoing process. We will see what will happen in the livestock food chain in Colombia with this example. We hope that other parts of the country can follow this example to include the gender perspective in this value chain. And to finish, I just want to give my take-home message, that is mainly that gender roles and gender relations significantly influence exposure to zoonotic diseases and can influence the prevention measures that we can have. Gender transformative policies and programs are really needed and address this and create the opportunities for change, not only for zoonotic preventions, but also for conservation of biodiversity. And finally, that if we want to have One Health national action plans that really work, we need to support gender equity and women's empowerment in those plans. And as our colleague Gabriel Lang said in a meeting, we can talk about One Health being the paradigm shift, but perhaps the paradigm shift that will deliver One Health is gender equity. So thank you very much. We are really willing to share our experience and to share knowledge and yeah. Thank you very much.
Thank you very much, Dr. Natalia. This was another very enlightening presentation. There is so much to say about it, but for the sake of time, I will concentrate on two things that really that you haven't summarized in your key take-home messages. That you really emphasize that following a One Health approach is already embracing equity, parity, and transdisciplinarity, and that integrating gender in prevention can have better outcomes. And you also show the responsibility as researcher to understand that and to better apprehend it in our research. And not only you're promoting research as part of the solution, as part of understanding, but also as part of the solution to really create opportunities for changes. So this is taking it one step forward and changing and transforming these gender norms, which are man-made. I really like these sentences. So changing and transforming these gender norms, which are man-made. And that is very great. Thank you so much. So now, without any further ado, I am very pleased to welcome Dr. Brigitte Bagnol, social anthropologist and research assistant professor at the Tufts University, and also the co-founder of the gender group at the Network for European One Health and EcoHealth. Brigitte, welcome. You will present us the AfroHoon program and the specific case of rabies control and elimination initiative in Africa, in which women play a decisive role in prevention. Thank you so much, and the floor is yours.
Thank you. Thank you so much for the opportunity. Can you see my screen?
Yes, very well, and in full screen.
Thank you so much. So what I'm going to do is I'm going to present a paper that we are preparing with a group of colleagues from AfroHoon. And the title of this paper is JETSI. JETSI stands for Gender Equality and Social Inclusion, Disability and Social Inclusion. And is JETSI consideration for risk communication and community engagement on rabies control and elimination initiative in Africa. So the paper was developed with a group of colleagues who authorized me to present on their behalf. Maybe first I need to present AfroHoon. AfroHoon stands for African One Health University Network. It's a network of around 26 institutions from 10 countries in Africa, working on One Health, teaching One Health, doing research on One Health. And in most of the curricula, in most of the research, the aim is to integrate gender issues. So this paper is an example of the work being developed by AfroHoon. So the presentation will have quite a classic content with introduction, method, result, discussion, and conclusion. Why did we decide to work on rabies? Because rabies is a very important public health challenge in Africa with around 25,000 deaths annually. And it's also really significant that there is a lot of lack of data disaggregated. Also, there is an understanding that children are most at risk, and specifically boys under the age of 15. So as my colleague said earlier, we are working on JETSI, we are working on integrating gender issue because we are aware of the differences between men and women in terms of risk of contracting some disease, in terms of difference in possibility to be tested, to be using adequate treatment, and in the possibility to recover from their disease very quickly. So we also understand that there is also a lot of differences in different groups of people, specifically with prisoner, refugees, and with people with disability. And the research aimed to try to understand this situation better, also trying to get a very holistic approach to address those social factors. In this picture, you see quite a common situation where you see children in rural area playing with dogs. In the research, 9 African countries participated in the research. The research methodology involved literature review, key informant interview, focus group discussion, and there was also a support from a gender expert who helped integrate gender issues in the tools and in the training and in all steps. But why this JETC and gender equality, disability, and social inclusion was emerging as a very important aspect, and why the colleague from AFROM wanted JETC aspect to be included? It's because they are aware and they are conscious that inequality fuels disease, and that disease tend to increase inequalities. And also because they understand that people are affected and affected differently by disease. And this needs to be understood and taken into consideration to develop any kind of program. So what was the process of integration of those JETC issues? The process of integration was basically started by a group of, let's say, gender advocate in AFROHOM, who decided that in the planning of the research, JETC issue needed to be incorporated at all stages. So it meant that even the research call required JETC lens. And gender training was given or suggested or proposed to the colleague. Then there was orientation on the way to integrate JETC issue into the protocol to make sure that the research would be gender sensitive, using gender sensitive tools, that the data would be analyzed with a gender lens, and then that this lens, this gender analysis would be reflected in the production of knowledge, in the packaging of the report, of the papers, and all the documents that were produced as a result. The result of the research indicate and confirmed that the most affected group of people are children between the age of 5 to 15, and mainly boys, and especially in rural area. Because in rural area, poverty limits access to vaccine and post-exposure treatment. The surveillance system is very often weak, and there is underreporting of rabies-related deaths. We also found out in the different research in the different countries that knowledge about rabies varies a lot according to social groups, according to education, according to gender, according to age, and according to occupational situation. We also understood that men are often perceived as the owner of the dogs, and they typically are the one who decide on the allocation of the resources in the household, and this includes the decision to vaccinate. While we also find out that women tended to be more attuned to health risk, and specifically risk affecting children, but that often they were not included into the discussion, into the training, into the conversation related to vaccination and related to prevention of rabies disease. So our thinking is that if data are not disaggregated, it's going to be very difficult for colleagues and veterinary institution to address the real situation for prevention, if they do not know the differences in terms of knowledge, in terms of situation of the different population. So it's extremely important to produce strategy documents that clearly outline the various risk population, and also to develop communication messages that are adapted to the specific groups of people and to the specific conception. It's also important from our point of view to have a champion on gender equality and social inclusion, to make sure that program include JETC aspects. AfroHome developed a responsive strategy in relation to the situation, and they developed segmented plans, including the different risk population. They developed an approach of community engagement where the specific needs and constraints of the different group were discussed with them. The colleagues were very sensitive to the differences into knowledge by the different group of population at risk, and develop messages together with the population to ensure that the message, the recommendation would be realistic and feasible, and at the same time scientific. The document developed and the plan had a multi-sectoral approach. To support this approach, AfroHome colleagues develop AfroHome JETC assessment framework, which is a kind of guideline, a kind of framework to do auto-evaluation, self-evaluation of institutional evaluation of different aspects of the implementation of their activity. It could be teaching, it could be curriculum development, it can be research, or it can be some projects, some programs, some intervention. So with a very clear and easy kind of scoring, A, B, C, D, A meaning that the implementation or the inclusion of JETC issue is good, quite good, quite efficient, B good, and C insufficient, and D very poor. It's a way for the colleague to analyze different activity to score their perception of the situation. So on the page, you can see one of the page looking at research, where you see the first point is ethical committee, and the question is the ethical committee trained on gender issue? So if the colleague thinks that the ethical committee is very well trained and very well sensitized in relation to JETC issue, they will mark with the code A, that means that it's very good, and so on. So this is a kind of guideline that is being used to assess the integration of JETC issue in the different aspects of the intervention. So in conclusion, what the paper advocate is for the integration of gender equality, disability, and social inclusion into rabies control program. because it's not only a matter of equity, but it's also an important factor to improve the program effectiveness. By including gender and JETSI issue in the communication programs, in the community engagement, in the intervention, the health intervention in relation to rabies, the control of the disease is going to be more impactful and contribute to the global goal of eliminating dogs-mediated rabies by 2030, in addition to allowing or contributing to the Sustainable Development Goal, which is also an objective of the program. So with this short presentation, I wanted to thank you very much.
Well, thank you very much, Brigitte. This was, again, a very practical and down-to-the-earth enlightening presentations. I mean, you have shown how we can really include all these questions practically into a research project on zoonosis disease such as rabies, and how not taking them into consideration brings out of vicious circles. And I think I really like the response strategy of Afroun and the very practical self-evaluation tool and framework, which could be very useful for other people to frame their research and evaluate how they manage to do that. So thank you very much. We have a very little time, and I think it will be very difficult to have an open discussion, but there was like question and answer done during the presentations. Well, it just shows how much more and how much things there is to say about this, and we need to keep talking about this topic. You have all demonstrated, the three of you, that science can help to unravel how inequality fuels disease and disease increase inequalities. And I'm taking your words, Brigitte, there because I really like them. And you have also very much highlighted the responsibility and needs for research to better integrate these issues. And you have given us some keys to do so. So thank you very much. So I would like to ask you one quick question before we close. Is how do you think that PREZODE can support this? How do you see PREZODE action to be able to really promote this integration of gender issues into research? In a few words.
If I may go quickly, Marisa, I could say that research questions should also include a concern about how do we ensure sustainability of the interventions that will be introduced during implementation. I think this is important for keeping a long process going. Thank you.
Thank you very much, Magda. Any other word on that?
Well, maybe I can suggest to follow the experience that I just presented, is that the experience of the colleague from Afrohome, who are trying to make sure that at all steps there is kind of possibility to be followed by gender expert or team of people who feel that they are champions. You know, you want to advocate for gender issue and to try to develop adequate guideline to help the colleague. I think the experience of integrating JETSI or gender, depending on the angle the project want to take, into the ethical committee, by example, to ensure that all the protocol that are seen by the ethical committee are fully integrating gender aspect. I think this is extremely important, and developing frameworks that allow individuals to check if they are doing the right thing, or help them to open their eyes on specific aspects. I think it's extremely important. As well as making sure that all the terms of reference of all the colleagues in the teams need to have responsibility in relation to gender issue and inclusion. I think this also help and oblige people to do also their self-autonomous kind of study. You know, there is a lot of things on internet. It's possible for people to train themselves if they have to, because they are obliged to fulfill their term of reference.
Thank you very much, Brigitte. This is very important. And I will leave the last word to Dr. Natalia.
Thank you, Marisa. Well, actually, what I feel that PREZODE can support is continue doing this information, capacity building in different regions. For example, in Colombia, we have a Ministry of Equality that start in this government, in the current government. And what I see that can be an opportunity is to connect with those governmental spaces to include the conversation of the preventing zoonotic disease emergence with those ministries, trying to understand the interconnection between equality and preventing pandemics. I think that you have a leadership roles, PREZODE, but you have allies at country levels, and we can also advocate to do that, to connect those conversations at government level and also with the NGOs like Conservation Society, like NGOs for animal welfare. We are all interested on this pandemic agreement to happen, and you are helping us also to do these conversations at many levels. Thank you.
Thank you very much. This was a powerful final words, and we will have further conversation on the pandemic agreement as well. But if we stay in this topic, so today was the second step in really increasing this dialogue on equities, equalities, gender, and we will talk more about it. And we are counting on all of you to spread these words and to improve this gender integration in our research. Thank you very much. Thank you all for joining us. Thank you, Magda. Thank you, Natalia. Thank you, Brigitte. And have a nice rest of the days, all of you. Thank you.
Thank you.
Thank you, Marisa. Thank you.
Thank you.
Thank you for people who came today.